My name is Jenna, and I am here to refute my opponent's claim that terminally ill patients should have the right to physician-assisted euthanasia. The first thing that my opponent touched on was his significance claim in stating that suffering is something that patients should be not forced to endure and have a choice as to whether or not they are going to end their own lives. There's a lot of research that I and my partner found which says that assisted suicide is never the only way to relieve excruciating pain and suffering, and that there are in fact some instances where terminally ill people do recover. For instance, there was a hospice nurse in a source that I found for 30 Logical Reasons Against Physician-Assisted Suicide, an article written by James St. Clair, published on July 29, 2009. A hospice nurse gave a 24-year-old woman 3 months to live, and 5 years later she's alive and well with a child. That's just one of many examples that I have. Another thing that I think is important to address when thinking about the amount of suffering that a lot of terminally ill patients experience, pain is never unmitigatable. You're never completely out of options when it comes to pain. The problem, I think, is that a lot of doctors today, a surprisingly small amount of doctors, actually never had a course in pain management, and according to the International Task Force, it's a national and international scandal that so many people do not get adequate pain control. So as opposed to killing people, I think a more effective way of solving the problem would be to educate healthcare professionals and the public. As far as my opponent's claim that hospice is ineffective and that it doesn't cure patients, hospice was never designed to cure patients. Hospice is set up as a means of providing, again, more pain control and a more comfortable and nurturing environment for people to spend their days if they do decide that they are no longer going to pursue any treatment options. And this brings me to another point, which is that no one ever said that, despite the fact that we may not be advocating the legalization of euthanasia, every patient, every person has a right to end their own lives. There's no law saying that you cannot kill yourself, that you cannot pull the plug, that you cannot refuse treatment. These are all options that we have. What we want to avoid is passing a law that will enable and encourage a slippery slope, which is probably something you're going to hear more of, which will encourage a slippery slope where in fact people will start to, where the lines will get blurred in terms of what is legal and what isn't legal. And the last claim that my opponent touched on is that the Oregon Death with Dignity program is effective today. And I do just want to point out that the claim has, or excuse me, that the program has only been in effect for 10 years. And in those 10 years, it's hard to say the amount of effectiveness it has or hasn't had, although we have seen that there has been a substantial number of an increase in physician-assisted suicides. One of the big concerns that's touched on by a few different sources. One is Dr. Edmund D. Pellegrino, the professor emeritus at the Medicine and Medical Ethics at Georgetown University, has said that his concern is, again, that euthanasia will create a slippery slope, and that it also, in places like Oregon and Belgium and the Netherlands, which are other places that it is legal, there's only 2 countries in the world, those 3 areas that I mentioned. The Oregon law it's quite possible that it could be offered and more in a replacement for health care. So essentially, critics like myself and my opponent are concerned that because the costs are so much lower, that it's actually going to be easier for people to opt to die than it is for them to receive medical care. And one quote from Dr. Pellegrino was saying that assisted suicide is a halfway house, a stop on the way to other forms of direct euthanasia, for example, for incompetent patients by advanced directive or suicide in the elderly. So one of the biggest things that we're concerned about is voluntary euthanasia a halfway house to involuntary and non-voluntary euthanasia. Involuntary euthanasia being euthanasia without consent of the actual patient, non-voluntary being the patient is not able to give consent. And the point that this doctor is trying to make, he goes on to say, if terminating life is a benefit, as in a cost benefit, then the reasoning goes, why should euthanasia be limited to only those who can give consent? Why need we ask for consent? So that just touches a little bit on the slippery slope aspect of it. As far as any other evidence, all I want to say is that there is a big cost benefit for big businesses, big insurance companies in this. As I mentioned earlier, it's a lot more expensive for people to treat terminally or very severely ill patients than it is to simply put them a lethal dose of whatever medication it is that they're prescribing. $75 to $100 was the last quote that I got, I think, from the American Medical Association, who is against physician-assisted suicide or euthanasia. And then I think the average chemo drug per month is something like $4,000 for Taravil, which was one of the newer chemo drugs that came out. So cost is another big thing to consider. And I don't think cost should be a driving force as to why we make the decision as to whether or not our grandmother or our mother or our father should live. So, yeah, that's, as far as, any refutations, that's about as much as I have, and thank you.